Let's talk of ventilators. And the ventilators we're going to be talking about can be something like this, something with a lot of options, a lot of settings, a lot of functionality. Something you might see on a critical care truck, or even at your just kind of typical 911 service who does some interfacility transports. We won't be talking about these little pieces of you know what, because they have, look at that, two settings. They've got breaths per minute, they've got tidal volume, and you can just click between the two settings. So you see there on tidal volume, we've got 800, we've got 600 for tidal volume. This dial just goes from 800 to 600. There's nothing in between. It just clicks from one to the other. You'll see these a lot just on pretty typical ambulance units, but we're not going to be talking about these because they are worthless and useless. We're going to be talking about these where we can actually think about what our patient needs and adjust it to what our patient needs. Now you've got your vent, you've got your patient. We need to set it, and we need to measure things, set things, and we're going to break this down into just 5 things. So 5 things that we need to know about our ventilator, about our vent. Really, all there is. There's 5 things. So first is rate, or VR is how we're going to and denote that. So we've got rate, we've got volume, VT, a tidal volume. So a rate in which um, we're giving breaths. We've got per breath, how large is that breath in our tidal volume. We'll talk about pressures here in a few minutes. We've got flow, this I to E ratio, this inspiratory-expiratory ratio. How quickly are we forcing the air in? How long are we letting the air come back out with expiration? So we've got air flow, and then we've got oxygen delivery. So that FiO2, the fraction of inspired oxygen, how much, proportionally, how much oxygen are we giving our patient per breath? A couple quick concepts to understand before we really dive into our vent patient. One of those is lung compliance. The other is airway resistance. So first, lung compliance. Compliance is how easily do our alveoli, do our lungs inflate and stretch during inspiration. So as I inspire, how easily pliable, how easily do my lungs stretch. If you want to do a formula, we can calculate compliance as change in volume over a change in pressure, and we call a compliant lung one that if we give just a little bit of pressure, that's going to be able to fully deliver the volume that I'm giving. So I'm giving a one breath via my vent, so the pressure going in for that inspiration, that inspiratory breath, doesn't have to be very high. So low pressure delivers the entire breath, and that's a compliant lung, what we'll call a compliant lung. Our non-compliant lungs, you might hear those called stiff lungs. Patients with ARDS, other pulmonary issues, might have stiff lungs, and knowing this, we just know we have to kind of pump up that inspiratory pressure going in. So as we are tweaking our vent settings, we need to know the health of our patient's lungs, and if we don't know the health of our patient's lungs, the first few minutes of our initial vent settings will tell us a lot. So this lung compliance is how easily the lungs inflate, how easily the alveoli stretch during inspiration. So a low pressure gives us the entire breath. We've got a good compliant lung. The other concept is that of airway resistance. So if compliance is how easily do our lungs stretch, alveoli um, stretch and inflate during inspiration. Airway resistance is how easily the air moves in and out to those alveoli. So we have to get air down to the alveoli first to determine compliance. So our airway resistance, how easily does the air just move in and out of our lungs, in and out of our system. So it doesn't have to do with stretching, right? We can have good airway or low airway resistance, I should say. We can have low airway resistance but a non-compliant lung, and we can have a compliant lung but a very resistant airway. So airway resistance, how easily does air move in and out? And think of this as friction, so our fluid dynamics. We talked a little bit the last unit about laminar flow, turbulent flow. We want lots of laminar flow, that straight line, just in and out, no impedance. We don't want turbulent flow where the flow is just bouncing back and forth and back and forth and back and forth as it moves down a tube. So when we have lots of turbulent flow, we have a lot of airway friction. We don't want that. We want low airway resistance, and we want a good laminar flow, And this goes into remember that Poiseuille's law, and that the radius of our tube, the size of that tube tells us how much flow we can get through it. So the larger we can make our tube, in this case our airway, the more flow, the more air we can get in and out of it. All right, now that we've got lung compliance and airway resistance kind of out of the way, let's talk about some specific settings. The first two are pretty simple. We deal with those every day, even if you're just bagging a patient or just looking at work of breathing and assessing a respiratory patient. First is respiratory rate, or documented as VR. Um, so we're setting a respiratory rate, usually 10 to 14 breaths per minute is our standard. And here, we put down metabolic acidosis, so um, there are instances where we won't be doing 10 to 14 breaths per minute. We've got that DKA patient. That patient's breathing at 30 times a minute to compensate for that metabolic acidosis. Well, we want to keep that going, right? So if we're going to RSI and vent our DKA patient, we're going to be setting that a little bit higher than that 10 to 14. But this is for your normal patient. If we were just to knock you down right now and put you on a vent, what we need probably 10 to 14 breaths per minute. We're also going to base that and look at carbon dioxide levels. We're going to be monitoring end tidal carbon dioxide levels. And so carbon dioxide starts going a little bit too high, we'll speed up that breath rate. Starts going a little bit too low, we'll slow it down a little bit. So we'll be watching our monitors after we set it. So we're going to be setting this vent, seeing how the patient responds to it, and then adjusting accordingly. Next setting going down, so we've set rate, and let's set tidal volume now. So for each breath, how large is that breath going to be? It's going to depend on your patient, how large your patient is. So we say somewhere between 4 and 7 milliliters per kg per breath. Um, and when we say per kilogram, that is not your patient's true weight. That is ideal body weight. So you can have a 500-pound patient who is 5'1". Well, we're not going to be setting our tidal volume based on that 500 pounds right there. We're going to say, what is the ideal body weight? What is the typical body weight for a 5'1" person? And we're going to base our tidal volume off of that. So you might see tidal volumes around 400, around 500, maybe up to around 600 or so. It just depends on your patient. So real quick calculation just to do there. Again, we're going to set it, see how our patient responds to it, and kind of go from there, right? So we're still looking for good chest rise, adequate chest rise, and we'll adjust as needed. We're also going to be taking into consideration and monitoring what's called minute volume. So we've got a tidal volume, which is a volume per breath. But we also want to take into consideration the minute volume, which is how much air they're moving every minute. So that takes into account both the tidal volume and the respiratory rate. And a typical adult is moving anywhere from 4 to 5 to 6 liters of air per minute. So we're going to be watching minute volume. Most vents just have a standard kind of default minute volume alarm on them. So if it goes too high, goes too low, it'll alarm at you and let you know. Next thing we're going to set is our PEEP, our positive end expiratory pressure. So we've set our rate, we've set our volume, and we need to set our PEEP, and we need PEEP for alveolar recruitment. We need our alveoli to stay open in between breaths, so need a little bit of PEEP. We generate just normal PEEP every single day. Just sitting here breathing, you're generating some PEEP, probably 2 or 3 centimeters of water, give or take, of PEEP just sitting here on the couch. So we're going to set it. If your patient doesn't really need any PEEP, there's no kind of underlying respiratory issue with your vent patient, we probably don't need any. You can leave it at 2, you can leave it at 3. Usually we start it at 3, just give you just a little bit extra, right? A little bit of support. If your patient does have some underlying respiratory issue, probably you need to start setting it, at 5, and go up from there. We can go pretty high. We can go 5 to 10 to 15 to 20. I'm not quite sure how high most vents go. I've seen some pretty large PEEP numbers, but we can increase PEEP as needed. Just know that as we increase PEEP, we're going to increase intrathoracic pressure. And as we do that, if we increase intrathoracic pressure, we're going to decrease venous return. We're going to decrease cardiac output. So your patient's blood pressure is going to drop. Is going to be the kind of the outward side of that. Your patient might not feel too good. If they're sedated and paralyzed, not a huge deal there, but you're going to see that in the vital signs, right? So you're going to see that one of the first signs would be that the blood pressure dropping. So kind of it's a balancing act what we do with PEEP, but just know that we will need PEEP to recruit our alveoli, and as we increase it, we're also increasing intrathoracic pressure. All right, a couple other pressures we're going to be keeping an eye on. One is peak pressure. You'll hear it called peak pressure. You might hear it called peak inspiratory pressure. Might hear it called peak airway pressure. This isn't something that we set. This is determined by your patient's airway resistance. And remember, airway resistance is how easily does air move in and out of the lungs. It's not compliance, not the stretch. This is just how easily does air move in and out. So peak pressure is how much pressure is needed to get air into the lungs. And your vent is going to deliver a breath and deliver a pressure with that to get the air in, no matter what that pressure is. So the default alarm is at 40 centimeters of water. If it goes over that, you'll have a pressure alarm go off. Your vent will let you know that it needs to use a lot of pressure to push that air in. So if we're looking at this graph right here, we've got peak pressure right up here. So we've got our PEEP. So we've got a little bit of pressure always in the lungs and the system. We deliver a breath, and right at this, whatever this pressure is, let's say it's 20, which is pretty common. Say it's 20, we are going to delivers that entire volume of breath. So we've told the vent to deliver 500 mils of air, and it's going to deliver that 500 mils no matter what the pressure. It's just going to alarm at you. So the default is at 40. So if your patient has some really stiff lungs, has some really gnarly lungs, has a lot of airway resistance, say it's a really bad COPD patient, there's a lot of airway resistance with COPD patients, we're going to need more airway pressure. So all we do is take that alarm setting and bump it up, bump it up to 50, bump it up to 60, because we still need that pressure to get the breath in. If we just have a pop-off valve there at 40, any of that air over, once it hits that 40 centimeters of water, it's just going to blow out the air, and it's not going to deliver it to the patient, so they're not getting a full breath. We still want them to get the full breath. So these peak pressures, these peak airway pressures, isn't something that we're going to be setting on the vent, but there's a default alarm, and then we can change the alarm settings a little bit if we want. Just know that there's a certain pressure that we need to get air into the lungs. So our peak pressure is determined by airway resistance, but we can also measure a plateau pressure, which is determined by lung compliance. So we've got our vented patient. Maybe we don't know much or anything about their lung history, their respiratory capacity. So we can look at peak pressures, and then we can measure this plateau pressure and come up with some ideas of what their airway resistance is like and what their lung compliance is like. With plateau pressure, there's going to be a button somewhere on your vent that holds the inhalation. So it's this manual hold to get this plateau pressure, and it just, for a couple seconds there, it just doesn't allow exhalation. And hopefully your plateau pressure should be less than 5 centimeters of water from your peak pressure. So if it's way off, we've got a compliance issue. So again, this isn't a pressure that we're setting. This is something that we are measuring. Same thing with peak pressure. So peak pressures and plateau pressures, those are determined by your patient, and there's nothing we can do about it. But it tells us about our patient's lung condition and how we should be adjusting our vent during transport. Now I've got peak pressures, I've got plateau pressures. What can we do with these since we don't set them? Your patient's body sets them themselves. We can look at our peak pressure. If it's too high, we'll say it's over 40 centimeters of water. And then we take a plateau pressure. We do that manual hold, get a plateau pressure. And the plateau is normal, but I have an elevated peak pressure. Well, I've got an airway resistance issue, right? I might have COPD. It might be an asthma patient. I've got a resistance issue. If I have a normal peak pressure, let's say it's 20, but my plateau pressure is elevated, right? It's greater than 5 centimeters of water off from my peak pressure. Well, now we've got a lung compliance issue, right? Might have an ARDS patient, someone with super stiff lungs. So we can use these in conjunction um, with each other to tell if we have a resistance issue, we have a compliance issue, and sometimes we've got both. Next, we're going to set our FiO2, or fraction of inspired oxygen. This is something we are going to set on our vent. It's going to start at 21% because 21% is the amount of oxygen in just normal room air. So as a vent delivers a breath, it's just going to pull it, in from room air, filter it obviously, and deliver it to the patient. Then we can go up to 100%, 100% oxygen being delivered to our patient. Typically, we like to start it at below 50%. If your patient can handle it, we're gonna start at 21% and just leave it right there, and leave it be just fine. But we'd like to start below 50%. As we get higher and higher and higher, we are going to be damaging our cilia within our respiratory tract. There's a huge bronchitis risk, inflammation risk, and there's a risk of atelectasis, creating those kind of hardened, stiff alveoli. So we don't want to be pounding in lots and lots of oxygen to our patient just because we can. These patients are going to be vented for a while. This isn't just a short-term thing. So we're going to start low and go high. Last thing we are going to set on our vent before hooking it up to our patient is going to be our IDE ratio, our inspiratory to expiratory ratio. So how long does it take you to inspire versus expire? So it's a given, it's a set time per breath, and for each inhalation and exhalation portion of that breath. So normally it's a 1 to 2. So if you think of this, it takes us about 1 second to inhale, about 2 seconds to passively exhale. So 1 to 2 is a normal. That's when you turn your vent on. That's going to be the default for your IDE ratio. If you know your patient has some respiratory issues, we're going to have to play around with that a little bit. If we have an airway resistance issue like COPD, asthma, we're going to have to set that IDE ratio a little bit wider, so like a 1 to 4. So it gives us a little extra time during that exhalation, because these patients have exhalation issues. They've got air trapping, right? So we need to give them a little extra time to exhale before the vent delivers another breath. If there are compliance issues, so lung elasticity compliance issues, we've got a stiff lung, we're going to have to kind of invert that IDE ratio, right? We're going to have a reversed IDE ratio. Maybe instead of a 1 to 2 or 1 to 4, now we have a 4 to 1. So we're pushing in the air a little bit more slowly with some pressure, and then the exhalation is very quick because they don't have an airway resistance issue, they have a compliance issue. If you have any questions, concerns, comments, or cuss words, please let me know.